Hi, everybody. Good afternoon or good morning, depending on where you are in the world right now. And welcome to our next installment of our PFF webinar series. Today, we'll be having a research update in pulmonary fibrosis. So we're really excited to hear from our speakers today. I am Amy Case. I'm a senior medical advisor for the PFF, and with me I have Dr. Gillian Goobie. She is at the University of Pittsburgh. Dr. Goobie completed her medical training in Canada at the University of Calgary and then at the University of British Columbia in Vancouver. And she is pursuing a PhD in human genetics currently at the University of Pittsburgh. And she's going to tell us a little bit about her PhD research that's focused on the role of air pollution in the development and progression of interstitial lung diseases. Also with us is Dr. Jeremy Katzen, who is a postdoc research fellow and ILD attending at the University of Pennsylvania, where he completed his fellowship in pulmonary medicine. He is in Dr. Michael Beer's laboratory, where he studied quality control dysfunction in the distal lung epithelium as it relates to parenchymal lung disease and pulmonary fibrosis. And he's going to tell us a little bit more about his research too. The special thing about these two folks that are speaking with us today is that they are PFF scholars. And I wanted to just mention a little bit. The PFF Scholars Program is one of the signature programs at the foundation, but many of you may not have heard of it before. This is a program that awards grant funding to support projects that early career researchers are doing in the area of pulmonary fibrosis. These projects can be anything from basic science to translational or clinical research, or epidemiology and health services research. And really the intent is to help people early in their career get started in this area so that they can be successful with additional funding from other sources such as the NIH. And our scholars have gone on to do just amazing, wonderful things over the years. So I'm so excited that you're going to get to hear a little bit about what Dr. Katzen and Dr. Goobie are doing in their research, but they are also going to give us an update on other parts of research in the world of pulmonary fibrosis, the things that have been happening over the last year or so that we haven't had a chance to talk about in one of these webinars. So I'm really excited about today. And I just wanted to give us a couple of reminders for our webinar. You are able to download the slides from your control panel, go to the handout section, and we have those slides available in PDF form. If you want to go to the questions section, you can submit questions that we'll try to address some of those, as many as we can during the course or at the end of our webinar today. If you would mind, when the webinar is ended, please stay on with us for just a minute or two and answer a survey, giving us some feedback on the session today. That will not be emailed later, so this is your only opportunity to give us the feedback as part of that survey. And toward the end of the session, we'll be giving you some information on our clinical trials finder at the newly launched PFF website. So Jeremy, if you can, I would just welcome you again and let's get into it. We have a lot to cover.
Thank you so much. So I'm an interstitial lung disease clinician at the University of Pennsylvania, and I do basic science research. That means I study basic pulmonary biology, focusing on the cells of the lung in systems like tissue culture and mouse modeling. And I thought the way I'd present some of my research today is kind of to put it within the context of drug discovery, which is really what we're talking about today, the path to clinical trials and to getting therapeutics to patients. I have no relevant disclosures for this talk. And what I thought I'd start with is how we go about an idea getting to an actual clinical trial. Because this is where I think a giant barrier exists in our field. So we start with a hypothesis, a novel therapeutic target that maybe comes out of looking at the explanted lungs of patients with pulmonary fibrosis. So a hypothesis is born. And from that, we start to understand it in cell cultures, which is called in vitro work, and then in model organisms, namely mice, which is in vivo work. And so maybe we start understanding the biology in these systems. If it seems like it is fruitful, we then identify a therapeutic strategy for it. Okay, how do we target this novel pathway? And sometimes that's with a compound, sometimes it's with an antibody. We'll be talking about that in the clinical trials today. And once we have it kind of tested in the cell culture system, we start moving it over towards the mice, and we test the pharmacotherapy in the mice, initially seeing if there's toxicology or toxic issues. And finally, and this is where I'm going to be talking about for the rest of this, is we start using it in preclinical models of lung fibrosis. Next slide, please. So pulmonary fibrosis, the biology of it is really, really complex. And I'm not going to walk through this figure from a review article published last year, but suffice it to say, I think a couple of important points can come from it without delving into the details. The first is we really think about this as a disease that starts in the lining cells of the lung called the epithelium, and really the lining cells of the little air sacs at the bottom of the lungs, the alveoli. And from there, a whole lot of very complex cell-cell communication networks start activating that eventually get us to the scar tissue that defines this disease, fibrogenesis. And yet, with all this complexity, the models that we've used in mice are relatively simplistic. And the most tried and true one involves using bleomycin, which is a chemotherapeutic drug that kind of damages the lung lining, the epithelial cells, and eventually gets fibrosis in the mouse lung. But it's a little bit oversimplistic, and it really doesn't capture the complexity of what we think happens in the human disease. Next slide, please. So my research focuses on rare genetic cases of interstitial lung disease. And I'm not going to delve too much into the genetics of IPF. I think that's really complex stuff. But there's rare occasions, especially in families where multiple members have disease, where we've been able to identify a specific mutation that's responsible for why these patients developed the disease that they have. And I focused on mutations in a certain type of protein in a specific type of cell in the lung called surfactant protein C. The project I've been working on that my PFF Scholars program focuses on came from a pediatric case of interstitial lung disease identified about 5 years ago. And so what I sought to do was use cell systems to understand how this patient went from having this mutation that they got fibrotic lung disease from. And I modeled it in cell systems, and that's shown here on the right, where I was able to express this protein, this kind of aberrant misfolded protein in epithelial cells in cell culture, and was able to identify what kind of dysfunction occurs in these cells. Next slide, please. And from this, I developed a mouse model where I'm able to turn on this mutation in the lungs of the mice. And similar to patients who harbor this type of mutation, they go on to develop these fibrotic lungs. And that's shown here in the middle, where we get these dense areas of fibrotic regions in the periphery of the lung that seems to look a lot like the pathology we see when we look under a microscope in an explanted IPF lung. Similar to the clinical disease in humans, when I look at lung function within these mice, I'm able to see that they have restrictive lung disease, so kind of the equivalent of low forced vital capacity on spirometry, and that's shown on the right. Next slide, please. And so from using this model, I've been able to kind of work out some of the mechanisms that start from that dysfunction in the lining cells of the lung, the epithelium, and been able to tease out some of the targetable points in the path to fibrosis. And that involves cell communication between the epithelial cells and immune cells, between the epithelial cells and the fibroblasts that lay down the scar tissue, and between the immune cells and the fibroblasts as well. Next slide, please. So I think this is a really exciting time to be working in this field, in part because I'm really excited about my model, but also because there's been a couple of other models that have been published in the last year that have similarly focused on kind of rare cases of driving mutations in order to have these mice develop spontaneous lung fibrosis. And we're collaborating with each other. The idea behind now these multiple models is that when drug companies develop a novel target or novel therapy, we can use these in these really translationally relevant models to test which ones seem to have the most promise before we bring them to human clinical trials. Thank you so much for your time.
All right, my name is Gillian Goobie, and as Dr. Case mentioned, I'm an internal medicine and pulmonary physician with board certification from Canada, and I'm currently living in Pittsburgh, Pennsylvania, where I'm completing my PhD in human genetics at the University of Pittsburgh. And I applied for the PFF Scholars Award in 2020 in order to pursue research evaluating how air pollution and other social and environmental factors impact patients with fibrotic interstitial lung diseases, or ILDs. And my research focuses on understanding how airborne pollutants impact clinical outcomes in patients with ILD and how it impacts ILDs on a molecular level. So specifically, I look at an area called epigenetics, which is the study of how molecules other than DNA itself interact with our genes in order to regulate which genes are turned on or off. And this field of epigenetics is known to be intricately associated with environmental exposures. And so a person's experiences throughout their lifetime, such as their exposures to pollution, can influence epigenetics. And this is a natural area to explore to help understand how air pollution may impact patients with ILD on this molecular level. So next slide. In terms of my disclosures, I'm the grateful recipient of funding from the PFF Scholars Program, as well as the University of British Columbia Clinician Investigator Program. So my research began with developing a method for determining how much air pollution a patient is exposed to. And to do this, I use a resource that was developed by the Atmospheric Composition Analysis Group at Dalhousie University that uses data from NASA satellites in order to produce estimates of pollution levels throughout North America. And these estimates are based on data collected from satellites that measure a feature called aerosol optical depth, which is essentially the haziness or opacity that satellites detect when they're looking down at the Earth that is not due to cloud cover. And they match these measurements up with ground-based measurements of air pollution, such as those through the Environmental Protection Agency ground-based monitors. And they pair that with their understanding of how these molecules interact and move through the air. And this produces an air pollution estimate, which has excellent resolution across the continent, as you can see in the bottom right hand of the figure here. And we can get down to approximately 1 kilometer squared in area for accurate measurements of air pollution. And these satellite-derived air pollution data provide much more accurate estimates of pollution exposure than most other air pollution estimation techniques, especially for individuals that are living in rural or remote areas. So once I access the satellite data for a certain time period, I can match this up with a piece of geographic information about a patient, such as their residential address or zip code. And that allows me to estimate their pollution exposure in that area over a period of time. And I can then link up these pollution estimates with clinical data collected through the PFF registry to see what effect these exposures have on outcomes like survival, lung function, and hospitalizations. Next slide, please. So using this approach, I performed a preliminary analysis of the impacts of air pollution on 410 patients with IPF, or idiopathic pulmonary fibrosis, that are followed at the Simmons Center for ILD at UPitt. And I'm going to be performing a similar analysis in the larger PFF cohort, but this is just the preliminary results. And here we're looking at the average levels of particulate matter with a diameter of 2.5 micrometers or less, and that's referred to as PM2.5, that patients with IPF in the Simmons cohort experience throughout the course of their disease. And PM2.5 is a key air pollutant that's associated with disease and worse outcomes in patients with ILD, and all manner of other conditions of the lungs, heart, and many other organ systems. PM2.5 is dangerous because it's very small and it can get its way down into the small airways of the lungs, where components of it can cause local irritation, inflammation, and damage. And some other components can even get absorbed into the bloodstream, which can result in impacts on organs outside of the lungs as well. And what we can see on the plot on the right that I'm presenting here is that the patients appear to have experienced lower levels of PM2.5 if they were diagnosed at a later point in time. So the patients diagnosed in 2015 and later seem to have lower overall PM2.5 levels of exposure over the course of their disease than the patients that were diagnosed in 2005 and earlier. And this may reflect the fact that air pollution levels across the US have decreased significantly over the past 50 to 60 years due to regulation, and that's great news. But nonetheless, many of our patients still experience yearly averages of PM2.5 exposure that sit above the recommended exposure levels set by the EPA and the WHO. And those are 12 and 10 microgram per meter cubed, respectively. Many of us, for example, may be experiencing higher PM2.5 levels right now related to wildfire smoke exposure. And there's evidence to suggest that PM2.5 levels as low as 5 microgram per meter cubed can be harmful to human health. And that's especially true for individuals with chronic diseases such as ILDs. Next slide, please. So the next step in my research was to look at how PM2.5 levels impact survival in patients with IPF. And this graph on the right here is showing the 410 patients with IPF that have been separated into 4 quartiles, where patients in quartile 1 or Q1 experience the lowest levels of PM2.5, and then patients in quartile 4 experience the highest level of PM2.5. So on the x-axis, we see the survival time in years, and on the y-axis, we see the survival probability, where we consider death or lung transplant as equal outcomes, where we stop analyzing the time after a transplant. And we can see here that there's a clear stepwise reduction in survival time when you go from quartile 1 to quartile 4 of PM2.5 exposure in the final years of disease. And basically, we found that patients living in the highest quartile of PM2.5 exposure actually experience a more than double the mortality risk compared to patients living in the lowest quartiles. And these findings support that air pollution is a very serious risk factor for bad outcomes in patients with ILD, which emphasizes the need for us to develop policies that reduce air pollution in our environments, which will help to protect individuals with chronic lung diseases such as ILD. Next slide, please. So my next research steps involve evaluating the impact of air pollution on clinical outcomes in patients enrolled in the PFF registry. I'll be repeating the similar analyses that I've already performed at the University of Pittsburgh. I'll be looking at multiple airborne pollutants, which include but are not limited to PM2.5. And I'll be extending to the molecular analyses that I briefly discussed before, looking at how air pollution affects an epigenetic marker called DNA methylation. And this is an important factor in controlling which genes are turned on or off that can be critical to the development of diseases like ILD. I'm also heavily involved in the American Thoracic Society Environmental Health Policy Committee, where I take an active role in advocating for policies aimed at reducing air pollution in order to protect patients with ILD and other vulnerable individuals. Next slide, please. So now I'm going to move on to a discussion about completed clinical trials in patients with ILD. Next slide. So first, before we get into the details, I wanted to provide a little bit of a background on clinical trials for those of you that might not be familiar with the structure and function of trials. So the clinical trial's purpose is to ensure the safety, tolerability, and effectiveness of drugs and other therapies used to treat a disease. Now, all clinical trials have very strict eligibility criteria that are meant to ensure that a common group of patients are being enrolled in the trial to ensure that there's effectiveness of a therapy in a specific disease state. And as you can imagine, this might be tricky when designing clinical trials for patients with ILD because there are over 200 different types of ILD. So many clinical trials will restrict which types of ILD patients they enroll. And the majority of early clinical trials in patients with ILD were restricted to patients with a diagnosis of idiopathic pulmonary fibrosis, or IPF. But thankfully, many of the clinical trials now are being opened up to other patients with different forms of progressive or fibrotic interstitial lung disease and different forms of autoimmune interstitial lung disease. So we'll be talking about some of those more broad inclusions today. Some trials may also have restrictions on how severe your disease needs to be at the time of enrollment into the trial. So it can't be too severe, but it needs to be a certain level of severity. And that's different for every clinical trial and its design. Enrollment into a clinical trial must be done with full and informed consent of the patient, given that there are risks and benefits to participating in a trial. And some potential benefits of enrolling in clinical trials includes the chance to receive new or potentially beneficial therapies at an earlier date, the fact that there's close clinical supervision throughout the duration of the trial, and the knowledge that participating in a clinical trial can help in the scientific development of new therapies that can help other people in the future. But there are certainly still some risks that anyone who is thinking about enrolling in a clinical trial needs to consider. So first, you may not receive any benefit from the treatment, and there's always a potential for harm from treatments that have not been studied before. There's also significant demands in terms of time, testing, etc., that you may have to go through in order to participate in the clinical trial. And lastly, if you're randomized in a clinical trial, which is important to ensure that there's no bias in the study, you may not receive treatment because you may be allocated to a placebo arm of the trial. Despite these potential risks, you should know that all clinical trials go through a rigorous process of ethical and scientific review before they're approved by institutional review boards at participating institutions. And this ensures the maximal safety and potential benefit to patients enrolled in these trials. Next slide. So there are several specific phases of clinical trials that are important to understand. Phase 0 are preclinical trials, including in animal and cell models, like Dr. Katzen introduced us to. Phase 1 involves a small number of patients that are aiming to determine an appropriate dose. Phase 2 increases the number of patients. It's generally randomized. It tests the dose and effectiveness of therapy. Phase 3 is in a larger number of patients, generally randomized, and is used to confirm safety, tolerability, and effectiveness of therapy. And after that point in time, a drug goes through FDA approval processes. And then phase 4 is a real world follow-up and monitoring after drug approval to confirm safety, effectiveness, and optimal use, and potentially trialing those therapies in other groups of patients. Next slide. So another important thing to understand is that clinical trials are designed to reduce bias. So they use techniques such as randomization, which determines whether patients are enrolled to treatment versus control groups. There's also something called blinding, which controls who knows what treatment group a patient is assigned to. So if a study is single-blinded, that means that either the patient or the doctor does not know the patient's treatment group. And double-blinded means that neither the patient nor the doctor knows what the patient's treatment group is. And lastly, placebo-controlled trials provide a placebo, which is often a pill or some other therapy that mimics a therapy being tested. Next slide. And the last thing I wanted to review before discussing recently published trials is why clinical trials can be terminated or stopped. So any institution that's running a clinical trial will have data monitoring committees who perform analyses on ongoing clinical trials before their scheduled completion date. And the purpose of this is to ensure that the clinical trials are being run ethically, safely, and that there are not any issues that indicate the need to stop the trial early. So some reasons for early termination of a trial include when there is an obvious or clear benefit to the treatment such that it would be unethical to continue to assign patients to a control group. If there's clear evidence that the treatment is harmful to patients in that the risks don't outweigh the benefits. If there's evidence of futility, which can result if the trial is not effectively able to recruit enough patients. And there are a myriad of other less common reasons that I've listed. And I just wanted to highlight here that we'll go over 2 trials today that experience early termination. And these are the Relief trial, which I'll get into, and the Galapagos Isabella trial that Dr. Katzen will discuss. Next slide. And Here I'm just highlighting what are the trials that I'm going to be discussing today, and those are the Census, Inbuild, Relief, the Mar et al. 2020, the Focus trial, and the Increase trial. Next slide. So to start is the Census trial. And this was a phase 3 trial that was published in the New England Journal of Medicine in 2019. And this trial enrolled 576 patients with systemic sclerosis associated ILD. And the primary endpoint in this trial was the forced vital capacity, or FVC, which is a key measure of lung function in patients with ILD that determines the maximum amount of air that you can breathe out from your lungs following a full deep inspiration. And they found that patients in the nintedanib group, that was a treatment group, had less decline per year in their FVC compared to patients in the placebo group. And patients treated with nintedanib only experienced a 52 milliliter decline in their FVC per year, whereas patients in the placebo group experienced a 93 milliliter decline. And on the bottom left, I'm showing the main figure from the article, which shows the absolute change in the FVC in milliliters over time from the start of the trial to week 52. And you can see that by the end of the trial, on the right-hand side, there's a clear separation of the two lines, with patients in the nintedanib group in the dark blue having a higher lung function than patients in the placebo group. They also looked at skin symptom severity and shortness of breath and did not find any difference in the nintedanib-treated group versus control for those outcomes. And it's also important to note that in this trial, as well as most other ILD-associated clinical trials, that the endpoint of interest generally focuses on lung function and most commonly FVC. And so this means that these studies are not generally designed to test whether there's a clear survival difference between patients on the drug versus placebo. They don't design these trials to test for overall differences in survival because this would require a longer and much more expensive clinical trial with much higher numbers of patients enrolled. And as a result, these types of trials are rarely done. So we need to look at evidence that comes out in subsequent analyses of the trial results, which are often called post-hoc analyses, to determine whether these drugs have any positive survival impact in patients with ILD. And this is all to say that the impact of these drugs on survival outcomes is not clear, but the FDA approves these medications and doctors prescribe them based on the knowledge that preserving as much lung function as possible is critical to the prevention of disease progression and death in patients with ILD. Next slide, please. So the next trial that I wanted to discuss is the Inbuild Trial, which was published in 2019 again in the New England Journal of Medicine. And this was a phase 3 trial of nintedanib in 663 patients with progressive fibrosing ILD, or PF-ILD. And PF-ILD is a relatively unclear term that is typically only used in the context of research, and it does not refer to any one type of ILD in particular. Instead, it refers to any type of fibrosing or scarring form of ILD where there's evidence of the disease progressing within 24 months of enrollment. And this is defined in the study by loss of lung function, worsening symptoms, and/or worsening CT findings. And to be clear, that's only the definition for this study because other studies have defined PF-ILD differently. The investigators in this study found that after 52 weeks on treatment with nintedanib or placebo, that patients in the nintedanib group on average lost 81 milliliters of FVC, whereas patients in the placebo group lost 188 milliliters. So you can see the separation of the curves again in that plot on the left, with the dark blue being the nintedanib and the light blue being the placebo. And with regards to side effects, they were similar to in the previous Census trial as well. And diarrhea was very common in patients treated with nintedanib, which occurred in about 67% of patients. There were also other minor side effects that were common in the nintedanib treated group, but there was no clear difference in the nintedanib group versus the placebo group in the risk of serious adverse events. Next slide, please. Next, I'll talk about the Relief trial, which was a phase 2b trial where they enrolled 127 patients with PF-ILD that was not idiopathic pulmonary fibrosis. So they excluded all IPF patients. They enrolled patients with a progressive form of ILD that was secondary to connective tissue disease, which is autoimmune diseases generally, hypersensitivity pneumonitis, asbestos-induced lung fibrosis, and fibrotic nonspecific interstitial pneumonitis. And in the study, they defined progression slightly differently from how they defined it in Inbuild by restricting the progression to only being defined by a loss of lung function, whereas in the previous trial, they would consider symptom progression and CT scan progression in order to include. And for a number of reasons, the study was much more difficult to recruit patients into than the Inbuild trial, because they were more restrictive in which patients could be enrolled because of the strict definition of progression, and because they had quite a bit of restriction of how severe the patient's disease needed to be at enrollment. And as a result of these limitations, they were only able to enroll 127 patients after several years of running the trial. And as such, the trial was terminated after an institutional monitoring board determined that there was futility in continuing the trial because of poor recruitment. And because of the early study termination, the authors used a modified statistical analysis approach. And as such, the results need to be interpreted with caution. But the data suggests that patients in the Prophetone group appeared to have an average decline of FVC of 37 milliliters per year versus 114 in the placebo group. So Prophetone's in blue and placebo's in red. And you can see that in the plot there. In terms of adverse events, nausea and decreased appetite were more common in the Prophetone group compared with placebo, whereas shortness of breath and respiratory infections were more common in the placebo group. Next slide. The next study is a phase 2b trial of Prophetone in patients with unclassifiable ILD. And for those of you that are not familiar with this term, this refers to a group of patients with fibrotic ILD that doesn't clearly fit into one diagnostic category. And these types of patients can be quite common, reflecting up to 20 or 25% of patients seen at specialist ILD centers. And so this trial aimed to determine whether Prophetone can be used as an effective therapy in slowing disease progression in these patients. And they were able to enroll 253 patients with unclassifiable ILD. But again, the investigators of this study made interesting decisions in the design of the trial by using home measurements of lung function instead of lung function performed in the clinic. And this led to some issues with the interpretation of results. So this does prevent us from making any solid conclusions about whether or not Prophetone is an effective therapy in patients with unclassifiable ILD. But they were able to perform a secondary analysis on the results by using lung function results that were performed in clinic during follow-up of these patients. And these results did suggest that patients experienced less decline in FVC in the Prophetone group compared with the control group. The FVC was an average of 18 milliliters lower than baseline in the Prophetone group versus 113 milliliters in the controls. And again, these results need to be interpreted with caution, but they do suggest that Prophetone may be an effective therapy in slowing disease progression in patients with unclassifiable ILD. Next slide. So now I'm discussing the Focus trial, which is a phase 3 trial which enrolled 210 patients with systemic sclerosis associated ILD and just patients with systemic sclerosis without ILD as well. And about 65% of their patients did have ILD. The primary endpoint was actually looking at the severity of the skin disease associated with this condition. And they did not find any benefit of tocilizumab, which is a medication that they were testing, in treating the skin symptoms. However, their secondary analysis was an analysis of lung function. And they did find evidence that patients treated with tocilizumab experienced less FVC decline and a longer time to treatment failure compared to patients in the placebo group. So patients with tocilizumab treatment experienced a 24 milliliter decline over the 48-week trial, whereas patients in the placebo group experienced 190 milliliter decline. And you can see that the tocilizumab treatment is in red and the placebo is in blue here. Adverse events were approximately equal between the tocilizumab versus placebo-treated groups, although injection site reactions to the tocilizumab were more common in about 8% of patients versus 3% in placebo. So this is an injectable medication, which is another consideration, as opposed to a pill like nintedanib and Prophetone. Next slide, please. And the last trial that I'll discuss today is the Increase trial, which is a phase 2/3 trial of inhaled treprostinil in patients with ILD who also have a diagnosis of pulmonary hypertension that is presumed secondary to ILD. And pulmonary hypertension is essentially high blood pressure in the arteries of the lungs, which can occur in patients with ILD who have a severe amount of scarring in the lungs and low oxygen levels that leads to narrowing of the arteries in the lungs and can impair the ability to pick up oxygen. And this is often a late-stage complication of severe ILD that can lead to worsened oxygen levels, shortness of breath, limitation in activities, and strain on the heart. And doctors who treat pulmonary hypertension have developed a number of injected and inhaled therapies that help to reduce blood pressure in the lungs. But these therapies have generally only been approved for use in patients that have pulmonary hypertension, not related to underlying lung diseases like ILD. So in this study, they enrolled 326 patients that had confirmed ILD as well as pulmonary hypertension secondary to that ILD. And different from the previous trials, which have been focused on baseline lung function measures, this trial used 6-minute walk distance as a primary outcome, which is a total distance that someone can walk in 6 minutes. They found that patients in the inhaled treprostinil group could walk farther than patients in the placebo group at the end of the trial. So the curve in red on the left is an inhaled treprostinil, and the curve in grayish blue is the placebo. So you can see that the distance walked is farther for the treprostinil group. They also found that patients in the treatment group experienced less clinical worsening, 23% versus 33%, which they defined as the occurrence of hospitalization for cardiac or pulmonary issue, death, lung transplant, or a 15% decrease in 6-minute walk distance. And in terms of adverse events, there was no significant difference in the number of adverse or serious adverse events between the treprostinil and placebo groups, although cough and throat irritation were more frequent in the treprostinil group. Next slide. And a subsequent analysis from the INCREASE study that was performed after the fact, or a post hoc analysis, also looked at lung function over time. And they found in the full cohort that FVC increased by 44 milliliters in the treprostinil group, as compared to approximately a 35 milliliter decrease in the placebo group. So this effect is quite unique and has not been seen in a number of other clinical trials before, that we actually see an increase in lung function. And this effect was more pronounced in patients with IPF and other idiopathic interstitial pneumonias, where the FVC increased by around 30 milliliters, as opposed to the placebo group decreasing by 130 milliliters. And these findings are very promising, as they reflect some of the first evidence of medications in patients with ILD that result in improved lung function. But much further research is needed to define exactly which patients with ILD will benefit from this therapy. Next slide. And that's all that I have for you for trials today. And I'm going to allow Dr. Katzen to discuss ongoing clinical trials in patients with ILD. Thanks for listening.
Thank you so much, Dr. Goobie. So I'm going to be talking primarily about 4 clinical trials. Then I'm going to briefly talk about Prophetone and non-IPF ILD studies that are ongoing. And I thought it'd be interesting to talk a little bit about what excites me about the biology of some of the compounds that are coming to clinical trial. Next slide, please. So the first one that I'm going to talk about is Pembrolumab in IPF. And this is a monoclonal antibody that targets connective tissue growth factor, or CTGF. And why does CTGF get me excited as a therapeutic target? Because it does a lot. It does a lot, and it activates a lot of different pathways that we associate with the development of fibrosis and kind of the activation of the cells that lay down collagen and scar tissue in the lungs. And shown here on the right side of the screen, the science images, what we can see is that in the lungs of patients with IPF, we see more CTGF. That's the kind of pink color in the bottom panels than we see in control patients. But what excites me really is the data on the bottom, which is showing that when we analyze the lungs of patients, explanted lungs of patients with IPF who are treated with pirfenidone and ertapenem, we don't see that those drugs lower the amount of CTGF we find in the lungs. Why is that important? Well, it shows that this is acting, or that this protein is not affected by the current available drugs, making it kind of an attractive therapeutic target for an add-on or additional therapy. Next slide, please. So Pembrolumab is a human monoclonal antibody. I think we all have learned a lot about antibodies in the last year. So antibodies are generally produced by the body. They bind to proteins. In the case of a vaccine, the goal is that they would bind to a viral protein. But in this case, it's a monoclonal antibody that binds to CTGF. And so it captures it, it sticks to it, and it keeps it from activating the receptors for it that are on those cells that I mentioned before, those fibroblasts. It's been about a decade since we started studying this in preclinical models in mice, and then phase 2 clinical trials have come out in the last 5 years. Next slide, please. So this is the large phase 2 clinical trial that gave us the equipoise for starting the phase 3 trial that I'm going to speak about. You can see it was roughly equal enrollment in those that received drug and placebo, about 40 and 40. And interestingly, when we look at the inclusion criteria, it didn't include patients who were on current antifibrotic medications. So you couldn't be on nintedanib or pirfenidone at the time of enrollment in these clinical trials. The majority of patients were male, most were Caucasian, and I think reflecting that this was a group that wasn't currently on antifibrotics, the time from diagnosis to enrollment was pretty short, 1.3 years. The drug is given by infusions every 3 weeks, and this was a long phase 2 trial, it was a full 48 weeks. Next slide, please. The primary outcome that they looked at was change in forced vital capacity. And you can see from the graph on the left that the drug kept the decline from being as severe as those that received placebo. On this right is showing their secondary outcome, which was disease progression. And they defined that as either a 10% loss in lung function by FVC or death. And you can see by that metric, the drug also was shown to be superior to placebo. Next slide, please. There were no significant adverse events identified in the study. Specifically looking at infusion-associated events, that was 20 in the Pembrolumab group and 14 in the placebo group. None of those were considered severe. And so, promising safety data from this. Next slide, please. And so based on this successful phase 2 clinical trial, the Zephyrus trial was launched. It's a phase 3 randomized control trial. Again, it's not involving patients who were on approved IPF therapies at the time of enrollment, though patients are allowed to be treated with the standard of care, which may involve initiating those drugs during the trial. The goal enrollment is 340 subjects. It's the same infusion schedule as the phase 2 trial every 3 weeks. It's about a full year at 48 weeks and the same outcomes as the previous, as the phase 2 trial. Next slide, please. So just kind of reviewing it, I think CTGF is a very appealing target for therapy, and based on the mechanisms I noted earlier. To remind everyone, it's an infusion. The phase 2 trial, 48 weeks is a long phase 2 clinical trial, but just remember it didn't include patients who were on antifibrotic therapy. And the safety profile from that phase 2 trial looks very promising. Next slide, please. So the next drug I'm going to talk about in clinical trial is PRM-151, which targets Penetrexin-2. Now, Penetrexin-2 gets me really excited because it works so differently from the other types of drugs we've really studied in pulmonary fibrosis. Penetrexin-2, it inhibits the activation of a type of immune cell that we think becomes kind of a bad actor in the lung and promotes fibrosis, so something called a fibrocyte. And when we look at the blood in patients with IPF and compare it to control patients, what we find is that patients with IPF have lower levels of Penetrexin, and that specifically among patients with IPF, lower levels are associated with worse lung function. Next slide, please. And so again, there's a long history of studying this in mouse models of fibrosis. Over a decade, we've been modeling this. And then, within the last 5 to 10 years, we've started looking at pharmacology studies in humans. And they've looked kind of like this graph on the left, where they've given infusions of therapies directed at Penetrexin-2, and then measured the amount of those fibrocytes, these kind of bad acting immune cells, in the blood of patients, and shown that the these drugs are able to lower the levels of those fibrocytes. Next slide, please. So the large phase 2 clinical trial was published in 2018. You can see the figure on the right shows it was a 2-to-1 randomization. So 2 patients received drug for every 1 that received placebo. And it was pretty large with 74 patients completing the trial who received drug. Patients in this one could be on current antifibrotic therapy. Again, it was predominantly in males. Most of the patients were on antifibrotics, and a little bit longer time from diagnosis to enrollment in this trial. It's also an infusion. This one's every 4 weeks, and this duration of the trial was about half a year, 28 weeks. Next slide, please. So the primary outcome in this trial, similar to the last, was change in forced vital capacity, and that's shown in the figures here. It met these endpoints, and because it included enrollment of patients who were on antifibrotics, they were able to break down the outcomes in the trial based on whether someone was on or not on an antifibrotic during the trial. And you could see from the graph, there was a trend towards improvement or less decline in lung function, regardless of whether the patient was on or subject was on or not on antifibrotics. Next slide, please. The secondary outcome in this clinical trial was 6-minute walk distance. And again, the patients who received drug had a preserved 6-minute walk distance at 28 weeks. Similar to the previous trial, there was no kind of signal towards serious adverse events in this trial, which again is promising. Next slide, please. And so based on the success of this phase 2 clinical trial, the Starscape trial began enrollment. Again, it's a phase 3 randomized placebo-controlled trial. Patients can be on IPF therapies at enrollment, so nintedanib or pirfenidone, similar to their phase 2 trial. It has a large subject enrollment, 658. That's a very robust number for a phase 3 trial. And then the infusions go like this. In the first week, it's 3 times. It's on day 1, 3, and 5. And then thereafter, it's infusions every 4 weeks for a full duration of 48 weeks, with the same outcomes being measured as the previous trials. Next slide, please. So what I think is interesting about Penitrex and 2, first, it's just an entirely different way of mechanistically targeting pulmonary fibrosis. To remind everyone, it's an infusion similar to the previous trial. The phase 2 trial, robust numbers, it was only 28 weeks long. And just to remind everyone, it was on, in patients who are on approved antifibrotics, and had a very, a promising safety profile as well. Next slide, please. Finally, I'm going to talk about Galapagos 1690 in IPF, and as Dr. Goobie mentioned, this was a trial that was terminated early. It's a drug that targets autotaxins. I'm not going to talk much about the mechanism here. Autotaxins are really complicated, but we believe they're involved in the activation of a bunch of different cell types that are involved in pulmonary fibrosis. Next slide, please. This was the phase 2 clinical trial data. So you can see they screened 72 patients, but ultimately were only able to enroll 23 in the trial, of which 17 received drug and 6 received placebo. And this is, on the right, is the change in forced vital capacity over the 14-week follow-up in this trial. So a relatively short trial, and maybe a trend towards preserved FVC compared to placebo. Next slide, please. So the Isabella trial was initiated based on that phase 2 data. It was a phase 3 randomized controlled trial. Patients could be on approved IPF therapies at enrollment. You can see they were targeting 526 patients. It's a daily tablet, so it's not an infusion therapy, and the goal duration was 52 weeks. The trial was terminated early, and what's noted is the reason was the benefit risk profile no longer supports continuing the study. I know when trials end early and we don't have a lot of information about the why, that can cause a lot of anxiety among patients and among clinicians, and we're just gonna have to wait and kind of hear a little bit more about what the signal was that caused the termination of the study. Next slide, please. Finally, I'm going to talk about inhaled nitric oxide and pulmonary fibrosis. And this is about pulmonary hypertension. So similar to what Dr. Goobie talked about with treprostinil in the Increase trial. So we know that some patient, a subset of patients with interstitial lung diseases develop this high blood pressure in the lungs, and that can be associated with more severe disease and increased oxygen needs. For a long time, we've also noted that inhaled nitric oxide in patients with other forms of pulmonary hypertension has therapeutic benefit. And so this was testing whether or not that's true for patients who have high blood pressure and lung pulmonary hypertension in the context or because of their interstitial lung disease. Next slide, please. This is the phase 2 data that was the basis for this phase 3 or clinical trial. You can see the numbers of patients enrolled, 19 who were receiving the inhaled therapy, 13 that were receiving inhaled placebo. It's really interesting what the primary outcome of this trial was very patient-centered outcome. Patients all wore a Fitbit that was able to assess how active they were being during a day, and was able to kind of assess what their maximum activity levels were, and used that as the primary outcome in the trial. And what they were able to show in this was that the inhaled therapy had more time spent in maximum exertion during a day compared to those that received placebo. Next slide, please. And so based on this, they began enrollment in the Rebuild trial. And it's important to kind of note the title of it, because that really captures who they're studying this therapy in. So it's in subjects with pulmonary fibrosis at risk for developing pulmonary hypertension. So the first part of that is pulmonary fibrosis. So this wasn't just idiopathic pulmonary fibrosis. This was actually all fibrotic interstitial lung diseases could be enrolled in it. And the second was, how do they define at risk for pulmonary hypertension? In this case, they were just looking at patients who were on oxygen therapy for more than 4 weeks. They considered that a risk factor for having or developing pulmonary hypertension. And so you can see the age range that they're studying this in. They do need, patients or enrollees do need to have a certain walk distance, as that's one of the outcomes. Their goal was 300 subjects. And again, the subjects in this clinical trial are getting the Fitbit that can measure their moderate to vigorous activity, and that's their primary outcome. Next slide, please. And finally, there's a number of ongoing non-IPF studies, all of which are now studying pirfenidone in non-IPF interstitial lung disease. So I'm listing them here: so rheumatoid arthritis, scleroderma, hypersensitivity, pneumonitis, and fibrotic sarcoid. All right, next slide, please. And just a great resource for patients and caregivers is the Pulmonary Fibrosis Foundation website, and specifically the Research and Clinical Trials portal that can give additional information about ongoing clinical trials. All right, and yeah.
That was great, both of you. Thank you so much. What a whirlwind. It seems like we've had the lost year from COVID, but there have been a lot of things happening, and a lot that we're anticipating as these studies start to thaw and start to recruit. And we hope to really see some exciting results in the future as well. So I just wanted to invite, we have a couple of minutes where we can answer a few questions. So I wanted to invite anybody who might have questions to drop those in our question box now. But we have, I actually have a couple of questions for Dr. Goobie about her research. One that I'll go ahead and ask, are PM2.5 exposure levels also linked to socioeconomic status?
That's a great question, and it's actually a significant component of my research that I'm doing in my PhD. So I'm looking at the intersection of air pollution and a measure called neighborhood level disadvantage, which is a surrogate for socioeconomic status, but it looks at a number of other factors of material and social disadvantage on a neighborhood level, and can kind of act as a surrogate for income and other factors. And definitely there's evidence throughout the US that does indicate that socioeconomic status and people of lower socioeconomic status and individuals of Black and non-Hispanic, non-white Hispanic race or ethnicity do experience higher levels of pollution exposure. So environmental justice is a really critical aspect of this research, and I think it's really important to elevate that issue on a policy level. So I'm trying to do that.
That's wonderful. Actually, one more question. These came in early, kind of while you were talking, but I didn't interrupt. Are the areas of highest risk the same areas in the EPA non-attainment regions?
Yeah, so generally the non-attainment regions are areas that exceed those EPA recommendations. For example, I live in Pittsburgh, which is Allegheny County, and Allegheny County often is a non-attainment zone, especially within specific aspects and areas of the county. And so when you're looking at it over the course of an entire year and you're looking at pollution exposures and estimates, typically the non-attainment regions and non-attainment zones are those areas that have the highest exposure to air pollution levels. Yes.
Great, thank you. We have a question about primary endpoints in clinical trials. I'm going to let Jeremy fill this one. So looking at the primary endpoints for most of these trials, do you feel that change in FVC is a surrogate marker for mortality?
That's a great question. I mean, it certainly historically has been, and it's probably I think part of it is the ease and part, you know, that we've used it for clinical trials, and part of it is the tradition of using it in clinical trials. You know, I think Dr. Goobie mentioned the home spirometry as an attempt to get away from the office-based metric, and I think increasingly we're going to see trials that use Fitbits and things that allow us to assess what day-to-day activity looks like. But yeah, I think for now, FVC is what we got, and it is used as our surrogate for mortality.
I think the reproducibility of that seems to be, you know, like you were saying, that very attractive to people who design the trials. And it does have correlation with mortality, even if it's not perfect. So it is something that takes less time. Gillian, you mentioned this, it takes less time to get to that endpoint. So a study can get done in a reasonable amount of time and get results and move on or not.
Can I mention one other thing about that as well?
Yeah, absolutely.
As we're getting to have more inclusive trials in the realm of interstitial lung diseases, where we're not only restricting to patients with IPF, we're also including other forms of fibrotic ILD, having mortality or death as a primary endpoint can be a little bit more difficult, because there are different patterns of disease and behaviors, natural history of disease, that can make it, you know, you're going to be following someone for much longer if they have one diagnosis versus another, whereas FVC and lung function is something that is fairly easy to follow across all of these different subtypes of ILD.
Absolutely. That's a really great point. Do we want to talk, just since we're talking about endpoints, a question about more patient-reported type outcomes and those that may be a bit more quality of life oriented for patients and these things. It's so hard to capture, but any comments on those? I know we collect them, but targeting those in these types of studies.
Yeah. Do you want to go ahead, Jeremy?
No, please go ahead.
At least one of the studies that I presented looked at shortness of breath as a secondary endpoint, and this is something that is being captured more frequently as a secondary endpoint in our trials as well. And typically we capture that through questionnaires like the St. George's Respiratory Questionnaire that will tell us how much shortness of breath people are experiencing in different daily activities. And there's other quality of life metrics and scores that can be captured in the course of clinical trials that are increasingly being incorporated into our clinical trials. But I think that that's a really important point, and it's very important that we have a more patient-centric and patient-focused approach to a lot of these clinical trials and our research in general to ensure that we're actually studying the things that are most important to our patients.
And if I could plug one other Pulmonary Fibrosis Foundation scholar, Carrie Aronson is a researcher at Cornell who's really devoting her scholarship towards developing better patient-centered outcome measures in patients with interstitial lung disease, because so many of the ones that we're using have been borrowed from other diseases and maybe aren't capturing the reality of patients with interstitial lung disease and kind of what are the challenges to quality of life.
That's great. Yeah, those are great points. Thank you. So I think we're a little bit over, but I do want to try and fit in one more question. Are there any research studies being done isolating a gene that may be causing ILD in familial lung fibrosis? I think this question is getting at specific research into familial pulmonary fibrosis.
Yeah, what a great question. The way I'd answer it is this. I think that a group at Vanderbilt is really at the forefront of studying both clinically and at a molecular level familial interstitial lung disease. And the way I think I'd answer specifically that question is they've identified that mutations in a specific type of family of proteins that help with telomeres, which are these kind of little caps to our chromosomes that we all have, are probably make up about 10 to 15% of mutations that drive familial interstitial lung disease. And they and a bunch of groups are working to develop models to understand how these mutations specifically drive disease, cause disease, and kind of open the door for studying specific therapies geared at that type of mutation. But that's all right now very cell-based, murine-based research.
And there have been some observational studies that have looked at the effectiveness of therapies like pirfenidone and nintedanib in patients with familial ILD that have both demonstrated that they are effective in slowing disease progression in patients with familial forms of ILD. Most of the clinical trials that we talked about don't exclude people that have a family history, and so there's nothing that prevents people with a family history from being enrolled in most of these trials. And so we are still doing research on that. But a lot of our data from a clinical trial standpoint is observational or post hoc, where they're not looking at that as the primary group. When they first make the trial, they're looking at it in the broader group, and then they're doing these secondary analyses after the fact.
That's great. Thank you, guys. I think we are out of time for our session today, but I just have to thank you guys, Dr. Katzen, Dr. Goobie, again, for being here, for all your work in the PFF Scholars Program and how you're furthering the research into pulmonary fibrosis. And thank you for teaching our group today. We've really, really benefited from this. If you did submit a question, we'll try to get back to you by email later. And just as a plug for our next session, the questions about genetics are well timed. We actually have a genetic counseling and familial pulmonary fibrosis webinar coming up late next month. So look for the announcement about that and registration coming in the next couple of weeks. A reminder that if you see our survey pop up, please fill it out so we can get some feedback. And thank you again, everybody, for joining us. This has been a great session. Have a great afternoon.
Thank you, everyone.
Bye.